Very delighted to have Dr. Atul Humar come and give today's webinar. Atul is the director of the multi-organ transplant program at the University Hospital Network in Toronto. And Atul is also one of the leads of our CNTRP projects that's focused entirely on infectious disease complications in transplant recipients. This is part of the work that we've done with the Canadian Society of Transplantation and Canadian Blood Services. And these follow guidelines that we were published, but now it's about trying to get this information and make sure that it's used by members of the community. So at this point, I'm going to turn it over to Atul to give a presentation.
Okay. All right. Well, welcome, everybody. Thanks for joining the webinar. So I'll get started. I don't have any relevant conflict of interest for this talk. So I'm gonna focus on the top bar here, the HIV, Hep C, and Hep B. But I just wanted to show on this slide that it's just one of many potential infections that can be acquired from donors. So I've just divided it here into the unknown pathogens, of which there have actually been many transmissions, especially unusual viral and a few unusual parasitic infections. And then there's the known pathogens, which the most common one we see is, of course, bacterial infection in the donor. And then CMV and EBV, of course, we knowingly transmit those to our recipients. And then what I'm going to focus on is donors who have risk factors for HIV, hepatitis C, or hepatitis B. So on the next slide, I've kind of listed the most well-recognized donor-derived pathogen infections. So on the top left are the viral infections, but in addition to the ones I'm going to talk about, viruses like rabies and West Nile virus and lymphocytic choriomeningitis virus have been transmitted. There are a number of parasitic infections, fungal, and bacterial infections that have been transmitted. Prion disease has been transmitted through corneal and through a blood transfusion, but not yet reported through organ transplantation. The literature is full of examples of donor-derived infection transmission, and many of these first descriptions are they're in the New England Journal and include some of the viruses that I've discussed. But there have been many transmissions, and then I haven't listed all the recent ones, but there have been many transmissions of hepatitis C reported in the literature, and a handful of HIV transmissions. So if we look at donor testing in Canada, the standard donor testing in Canada is first a screening by history, and this is usually from the family of the donor. The second step is the screening by our standard serology. So this includes the HIV, which is an antibody antigen assay, Hep B surface antigen and core antibody, Hep C antibody, and then syphilis, CMV, EBV, HTLV, and then usually bacterial cultures as well. We also commonly do NAT testing, so nucleic acid amplification testing, and this is variable in Canada, especially depending on where you live. But you can do HIV, Hep C, or HIV, Hep C, and Hep B altogether. Some programs will do West Nile testing during the summer months. And then these additional serologies are not usually done in Canadian centers, but are done in selected American centers. Just it's worth noting that in the U.S., NAT testing is now mandatory for all donors, and that's for hepatitis C virus, which means that essentially they get usually all three viruses checked. So the issues with donor testing in 2017, so one is the serologies can be confounded. So if you get blood products, you can get a false positive serology in the donor, and we see that commonly with CMV and EBV. If you get hemodilution in the donor, this can lead to a false negative serology. and then if you get recent exposure, so I'll talk more about that in the subsequent slide. Turnaround time, especially if you're in a remote geographic location, you may not have access to timely NAT testing. And then with both serology and NAT, there's always a potential for false positives,
will be arriving in New Station in approximately 5 minutes.
which leads to organ discard. So I'm going to just ask if you're on the phone, if you could mute your line or your speakers. Thanks. So this is a common case that we might get called about anywhere in the country. So it's a 25-year-old deceased donor who is found in a bathroom stall with a needle in his arm. The cause of death is drug overdose. The duration of hospital stay is 1 day. And the serology testing, the routine serology that we do, is negative. So typically we would do a NAT testing in that situation, and let's assume that the NAT is negative. So then the question would be, would you use the liver, heart, and lungs? And the options would be yes for any consenting recipient, yes for higher status recipient, and the third option would be decline. And I'll try to hopefully show you how this is developed and the data around this that can help make an informed decision. And then kidney people often think of their risk a bit differently because the patients do have an alternative. They can be on dialysis. But again, the three options would be yes, any consenting recipient, an alternate list recipient, or you could decline the kidneys. These are the summary of the CSA criteria, or the Health Canada criteria for increased risk donors. And they're a little bit longer than this, but this is the summary, and includes IV drug users, men who have sex with men, commercial sex trade workers, and then incarceration, and also non-sterile tattooing in the past 12 months. There was one. I just want to highlight a couple of notable cases of transmission. This is one that occurred in Chicago, and it was probably the most highly publicized of the transmission events, and it was multiple organs transplanted from a single donor, and the donor was a high-risk donor. He was a MSM donor, and the antibody for Hep B and Hep C and HIV were negative, and 4 recipients were infected with HIV and hepatitis C, and retrospective testing of the donor showed that the NAT was positive, so this was a window period infection. And back in 2007, of course, there weren't great treatments for hepatitis C, and 2 of the recipients actually died from hepatitis C. Another transmission case that was heavily publicized is 2 kidney recipients who acquired hepatitis C, and again, the donor was a high-risk donor, substance abuse, jail, but this time the hepatitis C antibody was negative and the NAT was negative, but when they investigated, the NAT was actually misread and it was actually positive, and this just highlights some of the other things that can go wrong even if you do all the testing correctly. And then finally, the 2 last transmission cases I want to point out. One was a transmission that occurred in Pittsburgh of hepatitis C from a donor to a recipient, and actually the donor was actually Hep C serology positive, but this was for some reason missed, like it was in the chart but not read properly, and the recipient developed Hep C. And then the other one was a HIV transmission, which there aren't that many in the literature, but again, this was a MSM living kidney donor, and then who was seronegative, but the last testing they did was actually almost 80 days prior to transplant, and an investigation, the NAT was positive 11 days pre-transplant. And basically, a lot of these cases have resulted in changes in the way that donor screening is done, especially in the United States. So for example, now at least NAT for Hep C is mandatory on all donors, And for live donors, the recommendation is that you have to do all your testing as close to the transplant as possible, and certainly within 30 days, and preferably closer. So one of the questions that's always asked is, well, what is the residual risk or the risk of transmission? And that basically means if the serology and the NAT are negative, what is the risk of transmission? And the answer is not very often, but it's clearly not zero. And it depends on the risk behaviors in the donor. So this is the window period of either serology testing or of NAT testing, and it just shows what window period means. So at the x-axis is time, usually in days, and the y-axis is viremia for the yellow line, and for the red line, it's antibodies. And you can see the antibodies generally take much longer to form, and so have a long window period, pathogen undetectable by serology, whereas the NAT, which detects the viremia, has a short window period. But the important thing here is the window period is still not zero, because there is a period usually of about a week where the pathogen is undetectable by NAT, and that's called either the NAT window period, or sometimes it's called the eclipse period. So these are the window periods for the three viruses. So for serology, for HIV, it's 3 weeks, and it goes down to about a week with NAT. For Hep C, you get the greatest benefit. It goes from 70 days to about 5 days or so, up to a week. It depends on what test you use. And for Hep B, it goes from about 40 days to 20 days. So if we think back to that case on whether you want to use that high-risk donors, I just tried to outline the pros and the cons. So the pros is that the use of organs from high-risk donors benefits the transplant community as a whole by expanding the available supply of organs. Also, the organs are of good quality, and I'll show some data, and the risk of transmission is low, and I'll show some data there. The cons is that a high-risk donor still has a non-zero risk of transmission. There might be some psychological stress that comes with the knowledge of that possibility, and that could either be psychological stress in the physician who accepts those organs, or it could be in the patient who accepts those organs. And the other thing is that a patient at the top of the list may receive a non-high-risk donor offer soon after, and so could be better off waiting for a non-high-risk donor offer. So based on this, the CNTRP and the Canadian Society of Transplantation developed a working group to look at increased risk donors, and this I've just listed the members here as well as the different societies that were involved. One of the things that group did was a mathematical risk modeling to determine residual risk in a Canadian population. And basically that involved looking at all the studies with Canadian data. And I just want to emphasize these are not transplant studies. These are incident and prevalent studies in cohorts of drug users or commercial sex trade workers, etc. And this just gives you an idea of the likelihood of an incident or a new infection over a given period of time. So what you have to think about is this way. So let's say if you have a donor who's been using drugs for 10 years, and you do the NAT testing and it's negative for HIV and Hep C, the question is what's the likelihood, if they've never been infected in all those years, that they're going to have been infected in the last 7 days? So you can imagine that likelihood is actually much smaller than most people think it is. And this is the results of that modeling that was done. This was published in this guidance document in Transplantation in 2014. So if you just look at the last column here, it shows the risk of, and this table is for HIV, so it's a risk of window period infection, assuming you're both NAT and ELISA negative. So let's say if you go to the IV drug user, which is the second row, the risk of window period infection is 1 in 3,700 for HIV. And that's assuming high-risk behavior right up till the moment of organ donation. So you can see that the risk is actually quite low, actually. So you can imagine even if you did 100 of these organ donors, if you used 100 organ donors like this a year, it would still be up to 30 plus years before you saw a transmission. Now for hepatitis C, the risk is actually higher, a bit higher than that. And this table is hepatitis C, and you can see that for IV drug use, it's 1 in 245 or so. So still a relatively low, but definitely higher than the HIV risk. And you can see some of the other categories like commercial sex trade worker or men who have sex with men and the relative risks there. So these risks are actually pretty good to quote to patients when you're getting consent. So I try to keep these tables relatively handy, and then you can quote the risk to the patient. Now, if you just compare that to like a crude waiting list mortality, and this is just data from CHI, this was also in that paper, and you can see that the waiting list mortality, even for kidney, is at least tenfold higher than the risk of transmission. This is data published by Rich Freeman, and just looked at what we quote as first-year post-transplant risk. And it's just a way to try to contextualize risk. And this is just risk of graft failure or mortality in the average kidney or liver patient or heart patient. So you can see, for the average liver patient who we might do with a MELD of greater than 30, the one-year mortality is 20% for all causes. So again, it's a substantially much higher mortality than the risk of that we're quoting with these high-risk donors. So if we think about the sort of three things to consider when you're contemplating using one of these organs is an individual level, so risk versus benefit of transplantation, risk of waiting until next available offer, or is patient on an alternate list. So for example, is the patient hepatitis C positive already and could accept a hepatitis C positive organ? Societal, so clearly the overall pool it benefits, and then programmatic, so a transmission incident may reflect poorly on a transplant program. These are some of what you don't want to be faced with. This is a headline in the New York Times after that Chicago transmission case. In the U.S., these cases almost universally result in lawsuits if transmission occurs. So again, something to think about. And they also, in the U.S., where UNOS very strictly regulates programs, it can lead to at least temporary closures of programs when things like this happen. The other thing to look at is, well, how good are these organs? And generally, if we look at, this is, again, data published by Rich Freeman, if we look at the quality of high-risk donors' organs versus non-high-risk donor organs, the high-risk donor organs are actually of better quality, and it's because they tend to be younger people, especially the IV drug users. So you can see that they're more likely to be between ages 18 to 30, and you can see they're less likely to be ECD kidneys. So they're good quality organs for the most part. This study looked at trying to compare the risk of getting HIV from a high-risk donor, and assuming that you died if you got HIV from a high-risk donor, versus dying from other things that people normally do. And they just tried to contextualize the risk, and you can see that the chance of getting HIV from a high-risk donor or dying from that is about very similar to rock climbing or doing rock climbing on a regular basis for a year. And it's much lower than getting being on the liver wait list with a reasonably high MELD or getting an ECD kidney, for example. And the same thing with transportation. You can see that getting AIDS from a high-risk donor, the chances of that happening are actually lower than dying if you drive a motorcycle, basically. Some things that some programs have done is use alternative lists for these increased risk donors. So, for example, they might have lists with older patients or HIV positive patients or Hep C positive patients or diabetic patients, or maybe patients with access problems, poor quality of life, multiple comorbidities, or a history of IV drug use. I think fewer programs are doing that now. I think things have sort of changed in that these organs are now being offered to really the next patient who comes up on the list. The other things to think about when you get these offers is that, you know, many donors are substance abuse, but they're actually not IV drug users. They're like cocaine snorters and other types of drug use. So we generally count those as increased risk donors, but actually they're at much lower risk than an IV drug user is. And also it's important to always ask how long the donor's been in hospital. So for example, if the donor's been in hospital for 7 days, and usually that means they haven't used IV drugs for 7 days, then if the NAT's negative, then this means it's a near normal risk, because if you remember, the window period for NAT is 7 days. The other thing to remember is that history in donors is often not reliable. So on routine donors, at least in Canada, we're not getting NAT. You know, one could argue that maybe those donors are not as safe as we think they are, and maybe the ones we are getting NAT on are, in fact, more safer. So those are just some things to think about. This was a survey that was done through the CNTRP of physicians and surgeons across Canada, and it just showed the likelihood of accepting one of these organs. And I'm just going to look at the yellow line, and the yellow line is if you get informed consent, the serology is negative and the NAT is negative. What's the likelihood of accepting the organ? And you can see it doesn't really matter what the risk category is. The likelihood's, you know, sort of in the 50%, 50 to 60% range. At least, interestingly, at that time, also for hemophilia, which is actually not a risk factor anymore for those types of infections. When we asked what the reasons for decline, the most common one was, understandably, it was worry about doing harm to the patient. But some of the other reasons, including legal action, transmission reflecting poorly either at a personal level or on the program. The other really important thing about using these organs is to make sure you get informed consent. And the easiest thing is actually if you have some kind of script that you can read from, which describes the risk to the patient, provides alternatives, and then you got to make sure you really document the informed consent process, because if you accept these organs, they will be as exceptional distribution. They won't. So you have to make sure you document that you got informed consent. As part of that consensus conference, we did draft, and Linda Wright did most of this work, where she drafted a potential script that could just be read to the patient, and you know, programs could modify this as they see fit. But it basically says, you know, explains what is meant by an increased risk donor and what testing your donor had, and then what you have to say is the likelihood of transmission is X, and you can take that from that table, basically, those two tables that I showed you. The other thing I think that's dramatically changed, actually, even since we did this consensus conference, is that now, most of us recognize that hepatitis C is very easy to treat and very easy to cure. The biggest hurdle is actually just getting the medications and the cost of the medications. But really, almost everybody with any genotype now can be cured with a 12-week course of therapy, and sometimes even shorter, and it's usually just one pill a day for 12 weeks. So I think transmission of hepatitis C does not carry the same clinical burden as it used to, and there's now even trials going on, and we're starting one as well, looking at transplantation of donors that are known to be Hep C positive into Hep C negative recipients, and then treating those recipients. And HIV is, I think, a more worrisome thing to transmit. You certainly don't want that, but remember the risks of transmission of HIV were substantially lower. Treatment for HIV has come a long way, and now it's usually just 1 or 2 pills a day with good viral control achieved. So the important thing, if you do use these organs, and this is something that we found is not universally done, is to test the recipients afterwards, because you want to make sure you pick up a transmission right as soon as it occurs. So, and the other important thing is to pick up transmissions, you have to do NAT in the recipients, because they might not mount an antibody response, especially for Hep C, they might not mount Hep C antibodies, so you have to do a NAT, and this is in that consensus guideline, we put forward this as one potential algorithm for post-transplant testing. This is just a PDF of that paper that was published. This was the final recommendation. So what we suggested was that transplant physicians should definitely consider using organs from IRDs. This should be done with NAT testing. So if you don't have NAT testing available in your jurisdiction, then I would recommend not using these organs, because I think you would set yourself up for potential problems medical, legally, and both safety-wise. I think what we said was all potential recipients should be made aware of this option to consider accepting organs, and that declining such an offer will not impact waiting time for a standard risk organ. And you can imagine it's best to have these conversations well beforehand rather than in the middle of the night when you get the organ offer. You need to do it again at that time, but if you've had it once before, it makes it easier. And then appropriate informed consent is really critical and should be provided. You can get some degree of consent beforehand, but you really need to get it at the time you offer the organ again, and that needs to be documented. And then you can take into account other things such as, how long the donor's been in hospital and things like that to help you determine the risk. Now, I just want to say that if all of these organs were used, it compromises a pretty substantial portion of donors. It's probably around 15% of donors are categorized as increased risk, so it's a pretty substantial portion of the donor pool. Trillium, the OPO in Ontario, put together, based on this publication, put together a increased risk donor toolkit, and basically the kit has everything I've just outlined is in this kind of one document for use either as a reference document or at the bedside, and then they distributed this to all the programs in Ontario. So I will stop there, and we can have questions or discussion, and thank you very much.